I wish if we can wait for a couple of minutes more before I give you an insight about this, webinar series on endometrial receptivity analysis. Let's allow some more distinguished doctors to join us. Please bear with us. The only purpose is that majority of the fraternity should be benefited. Thank you very much for your patience. Currently, we are almost 21 in number who are in the audience. So I think it makes sense if we wait a bit more. In the meanwhile, before we start the session, I would like to request each and every participant, any question you have, any query you have, you can just write it. You can see the chat box, on your screen. You can just click on that. A dialog box will open. Just punch in your question and post it. So once the deliberation is over, I'll be reading out your question to the presenter. Sorry for the moderation. Yeah, we are now almost 30. Another 1 minute and we'll hit it. Okay, so here we are. Warm welcome to all the distinguished ladies and gentlemen, the participants. Thank you very much for taking out your time this evening to attend to this series of webinar, which is on endometrial receptivity analysis. Actually, the whole series is based on the topic, that is the proper protocol, that is the compliance or proper protocol to optimize your clinic's error outcome. That is the purpose of the series of this webinar. And today we are starting with volume 1, and here we will be focusing on the importance of endogenous progesterone control. And when we talk about uh, the speaker is Tiffany. Actually, Tiffany is the global director of Endom Trio, and she's based out of US. Tiffany Stankiewicz earned her, this is just an introduction I'm giving you about her, very pertinent, so that you know who's talking to you. Tiffany earned her bachelor's degree in animal biosciences from the Pennsylvania State University and a PhD in genetics from University of Kent, where her thesis centered on optimizing IVF outcomes by controlling for both embryonic aneuploidies and endometrial receptivity using genetic testing. So, yes. uh, Tiffany has over 15 years of clinical laboratory experience as a fully trained embryologist certified by the American Board of Bioanalysts as a technical supervisor in embryology as well in andrology. In addition to clinical laboratory experience, Tiffany coordinated many aneuploidy and single gene cases as PGT director at a large IVF clinic in Philadelphia. Tiffany made the move to reproductive genetics in 2016 when she became the PGTA lab manager at iGenomics New York. In 2017, her primary focus in the company shifted to endometrial testing when she took on the role of endometrial specialist, concentrating on ERA, EMMA, which is a microbiome service from iGenomics, as well as ALICE, which addresses chronic endometritis tests. Today, she serves as the Global Endometrium Product Director for iGenomics. Tiffany has published and presented research at congresses such as the Pre-Implantation Genetic Diagnosis International Society, the American Society of Reproductive Medicine, the European Society for Human Reproduction and Embryology, and the Pacific Coast Reproductive Society. Tiffany is an instructor at Eastern Virginia Medical School and is a member of the American Association of Bioanalysts, the College of Reproductive Biologists, and the American Society of Reproductive Medicine. This is quite heavy, Tiffany. Let me welcome you. Thank you very much, Tiffany. This was really, on the cards, this program. Thank you very much for being with us today and addressing the gathering here in India, gathering of distinguished doctors. I welcome all the doctors to this webinar, and my thanks and my heartiest welcome to you, Tiffany. I hand over the session to you now. Yeah, before that, since all the doctors have joined now, I mean to say they're still joining. So my request would be, if you have any question, right? Because this is the platform wherein we cannot speak to each other. So you can see a chat box on the screen. When you click on the chat box, a dialog box will open. You can just punch in your question in that space. And once the program presentation is over, I'll be reading out your questions to Tiffany. Anything else, kindly write in the chat box. Thank you very much. Over to you, Tiffany.
Thank you, Vikram, for the introduction. I'm very happy to be here today, especially speaking about a topic, how to optimize our ERA outcomes. So as you can see, my PhD focused on optimizing IVF outcomes. So this is just another way, hopefully, that you can learn to optimize further the endometrial receptivity analysis in your own clinics and patients. So before we get started in discussing the importance of endogenous progesterone, I do want to give a quick introduction. So implantation is a significant rate-limiting step in both human reproduction and IVF, and we know that it hinges largely on two essential players, the embryo and the endometrium. So for years, we have focused on optimizing the embryo. This is including moving over from conventional IVF to intracytoplasmic sperm injection. We've optimized the culture media in which we grow our embryos. We optimize the culture systems, such as the incubators we use. And we've optimized our cryopreservation, moving from slow freezing to vitrification. And then more recently, we've more widely introduced pre-implantation genetic testing, specifically for aneuploidy screening. With that said, implantation failure still occurs in 1/3 of PGTA transfers. So even though we're controlling and finding the best possible embryo in a cohort, it does not guarantee success. With that said, we need to start looking on the other side of the equation, which is the endometrium. Now in 2011, iGenomics introduced endometrial receptivity analysis. This was a molecular assay used to determine each woman's unique, personalized embryo transfer timing, therefore synchronizing the embryo transfer with the individualized window of implantation. Here, we use next-generation sequencing to look at the expression of 248 genes that are involved in endometrial receptivity. After sequencing, we use an in-house designed computational predictor or an algorithm, and then we classify the endometrium as either being receptive or non-receptive. The result is then coupled with a recommendation for a personalized embryo transfer according to each patient's specific endometrial profile. In fact, the ERA test was brought to market as a solution for those women experiencing implantation failure. As far as research supporting ERA, we have over 26 publications at this time supporting the use of endometrial receptivity analysis. The research conducted by iGenomics has demonstrated that synchronization between an implantation-ready embryo and a receptive endometrium increases the chances of success in assisted reproductive treatment. In addition to internal publications, there are even more external publications from other groups showing similar results from their own patients after guided embryo transfer according to the ERA results. As it has been demonstrated that synchronization between an implantation-ready embryo and a receptive endometrium with ERA increases the chances of success in assisted reproductive treatment, how can we replicate these same findings from these published studies to optimize our own ERA clinical outcomes for our patients? And this leads me to ERA protocol compliance. Why is protocol compliance so important when it comes to ERA? The answer is reproducibility. So during the ERA mock cycle, we take the biopsy if it's in an HRT cycle, approximately at 120 hours of progesterone exposure. If in this example, we were to find that the patient was receptive at time of biopsy, then in the transfer, we're going to perform the biopsy again at the transfer at exactly 120 hours of progesterone exposure, because we want to replicate the findings of the ERA mock cycle. Now, along with that, not only do we need to replicate the timing, so again, 120 hours of progesterone exposure, but we need to replicate the conditions and the cycle type So if we're using an HRT cycle in the mock cycle, we need to use an HRT cycle in the personalized embryo transfer or PET cycle. Again, we want to replicate the findings of the time, so 120 hours at the biopsy, found receptive, then we should transfer 120 hours in the PET cycle. But even beyond cycle type and proper timing, we also have to look at conditions of the uterus, including endometrial thickness. Do we have similar thickness between the mock cycle and the transfer cycle? But also the progesterone medications and other medications we're using in that cycle. So for example, in the ERA mock cycle, if we're using 400 milligrams of vaginal progesterone twice a day, we want to use the same exact progesterone protocol and do the 400 milligrams of vaginal progesterone twice a day in the PET cycle. So you could see here, we're replicating everything exactly in order to ensure reproducibility, to ensure that the results that we found in the ERA cycle are going to accurately be transmitted to the transfer cycle. So let's talk about reproducibility in ERA in general. So in 2013, our group published a paper about not only the accuracy of the ERA test, but also the reproducibility of the ERA test. Here, biopsies were taken anywhere from 29 to 40 months apart in 7 patients. They were taken at random times during the menstrual cycle, but again, replicated from one biopsy to the next. So for example, if we look at patient A, the endometrial phase in which the biopsy was taken was on LH+7, whereas patient E, the biopsy was taken in the proliferative phase at day 9. And what we found was total concordance between the first biopsy and second biopsy between all of these women. This indicated that transcriptomic variation between cycles, even 3 years later, is quite rare. Now, this has been challenged in the field. So we have a lot of physicians that think, well, of course, why wouldn't we expect the endometrial transcriptomic signature to change from month to month? Are the ERA results and transcriptomic profiles actually consistent between different cycles, even within the same women? And this was a letter that was published from a group in Canada back in 2018. And in this particular letter, they shared a patient experience. So these were results from all the same patient. You can see here that the patient underwent 4 different biopsies. In her first cycle, the biopsy was taken at 106 hours of progesterone exposure. So a bit earlier than 120 hours, still fine. It just puts her at a higher risk of having a pre-receptive 2-day result, which then it puts you at a higher risk of having to perform a second biopsy. This is why we prefer 120 versus an earlier hour, let's say. Now, what did the ERA result indicate? It indicated pre-receptive 2 days, and the recommendation was to perform a new endometrial biopsy at 154 hours of progesterone exposure. So when the patient came back for ERA number 2, however, they performed the biopsy at 194 hours, so an additional 40 hours beyond our recommendation. Of course, we obtained a post-receptive result, and we said repeat the endometrial biopsy at 170 hours or 24 hours earlier. So again, when it comes to post-receptive results, we can only give a 24-hour earlier result or a 12-hour earlier in the case of late receptive. So then they did follow the instructions this time and did the biopsy at 170 hours. And again, it came back post-receptive. And we said 24 hours earlier, perform a new biopsy and at 146 hours. So finally, in the 4th biopsy, they biopsied at 148 and a receptive result was achieved. Now, you can see that we indicated perform embryo transfer very early on, halfway through this patient's sequence, because we had already identified that the window of implantation was likely to be near 154 hours. So to answer the question, Are ERA results and transcriptomic profiles actually consistent between different cycles? Yes. And let me show you using the same patient in this instance. So in response to this publication, our group wrote a letter actually thanking the authors, showing the consistency of the ERA testing outcomes and its predictions. In this case, the author performed an ERA test in one patient, and after receiving the report with explicit instructions on how to proceed, instead performed the subsequent endometrial biopsy at a moment completely discordant from the original recommendation. And I'll show you here. So you can see the first biopsy at 106 hours was pre-receptive 2 days. We recommended a second biopsy at 154. Now, again, as I explained in the previous slide, they did not follow our initial instructions, and instead of biopsying an additional 48 hours later, they biopsied an additional 88 hours later, and of course received a post-receptive result. But after the number 2, 3, and 4 biopsy, you can see that the window of implantation lied right within this area here, which if they had just followed the second biopsy, they would have achieved a receptive result on biopsy number 2. So not only does this demonstrate the importance of following the ERA report and replicating our recommendation as indicated, but it also demonstrated that yes, the ERA test and the transcriptomic profiling accurately shows the window of implantation in a patient is consistent from month to month, but also that it shows that the rest of the endometrial phases are also consistent because we see a nice progression from at 106, the patient is pre-receptive 2 days, 170, 194, she is post-receptive, and around 146 to 154, she's found to be receptive. So again, we thank the authors for demonstrating reproducibility of the ERA results from month to month. Now, what can affect the reproducibility of ERA? I already went into this in a bit at the start of this, but let's go through the list again. So overall adherence to the recommended PET timing. So as we saw in the last example, if we say that the patient is, let's say, receptive at 144, it's important to perform the personalized embryo transfer at 144. Replicating the cycle type. So if you're using an HRT cycle in the mock cycle, you want to use an HRT in the transfer cycle. Same thing with natural. If you apply a natural in the mock cycle, you want to apply a natural in the transfer cycle. So again, this cycle type needs to be replicated in both the ERA mock cycle and personalized embryo transfer cycle. But not only do we need to replicate this cycle type, but we need to replicate all cycle medications. So for example, progesterone administration type, if we're starting with vaginal in the mock cycle, we continue with vaginal in the transfer cycle. This also applies to the dosage. We don't want to adjust the dosage during the preparation up to transfer. So everything needs to be replicated as far as medication, administration type, dosage, etc. in both the mock and PET cycles. We also need to consider the use of additional medications. How can medications like gonadotropins and steroids affect their reproducibility? So for this reason, the ERA test is not validated in fresh IVF cycles because the use of gonadotropins and the superphysiological levels of the patient's hormones can affect the reproducibility of the ERA results. So that's why ERA is reserved for frozen embryo transfer cycles utilizing either HRT or natural. Now, this is surprising for some physicians, is that major shifts in the patient's BMI between the mock and PET cycles can affect reproducibility. And why is this? Well, since the endometrium is hormonally regulated, the change in a patient's BMI can affect how we metabolize hormones and hence affect the endometrium. So if your patient does have a change in BMI, say they go from a normal BMI to obese BMI or obese to normal or underweight, it could be reconsidered repeating the ERA results to see if there's been effect on the reproducibility. We also know that women with a BMI of over 30 have increased chance of displaced window implantation versus women with a BMI less than 30. Alterations to the uterine cavity. If you are planning on performing any alterations to the uterine cavities, for example, if there's any surgeries or treatments, they should be done before the ERA mock cycle. If it's done between the ERA mock cycle and the transfer cycle, this again may affect the reproducibility of the results. Endometrial thickness and pattern. This is also very important. So if you have a patient who builds quite a nice endometrial lining in the mock cycle, let's say 9 millimeters, but then in her transfer cycle, her endometrium is atrophic, less than 6 millimeters, then the results may not be reproducible. It's always important to make sure that endometrial thickness is within a certain range between the ERA mock cycle and the personalized embryo transfer. So for example, it should be either less than 6 millimeters in both cycle, between 6 to 12 millimeters in both cycle, or greater than 12 millimeters in each cycle to help ensure reproducibility. And then finally, elevated endogenous progesterone levels. This is very important, and I'll go into more detail since this is what this volume pertains to. So how do we ensure ERA reproducibility? Proper protocol compliance. This is key when you're performing the ERA test. So unfortunately, we see that protocol deviation is common. We've seen this in our own studies. So in our own randomized controlled trial published in 2020, we had a 50% dropout rate. This was 30% higher than the anticipated dropout rate that we initially calculated at the beginning of this study. A large contributor to this dropout rate was no protocol compliance. And you can see here one of the figures of the paper, I highlighted it. It showed the number of patients in each group in which no protocol compliance was achieved. Now this goes beyond even our own studies. There was a paper published in 2022 by the EV group, it was Cozzolino et al., in which not only did they indicate poor the ERA with personalized embryo transfer did not provide benefit, but they actually had poor outcomes in the ERA PET arm versus the FET or fresh ET arm. Now, the patient population they were studying here were good prognosis patients, not the indicated recurrent implantation failure patients for the ERA test. Now, what was interesting is that this same group participated in our own RCT, which was the RCT I shared on the previous slide. So we had the data from those patients belonging to the EV clinic that participated in the RCT. And when we looked at the data compared to what Cozzolino shared in their retrospective data versus the clean RCT data, we actually saw that the personalized embryo transfer with ERA had much, in some cases, significantly higher clinical outcomes compared to the frozen or fresh embryo transfers. So again, these were in their retrospective data. They used the same patient population that was applied in the RCT, except the only difference here is that the data we see from the EB patients from the iGenomics RCT was the clean data. And what do I mean by clean data? It was the data where we ensured proper protocol compliance 100%. So we can see here, when the ERA is performed with proper protocol compliance, we have much higher clinical outcomes with a personalized embryo transfer versus with ERA versus a frozen and fresh embryo transfer. Very different than what they had presented in their retrospective data, but it is suspected that probably many of these patients weren't controlled for protocol compliance. So for example, maybe lack of endogenous progesterone. Did they perform the transfer at the indicated time? Were the cycles replicated? This was unverified. With the RCT, we had the advantage of properly verifying. But even so, if we remember, RCTs require extreme scrutinization to only include the clean data. If a 50% dropout rate was observed in patients participating in RCT, what would the dropout rate be in clinical cases where we don't have the oversight of a clinical studies team ensuring that everything is followed properly? And that is the question we have to ask, and perhaps the reason why we saw such a big difference in the data they presented versus the data from their own patients in our RCT. So again, we went through what can affect the reproducibility of the ERA results. As we know, we're going to focus on elevated endogenous progesterone levels. So how can elevated endogenous progesterone levels affect reproducibility and hence clinical outcomes for our patients? Well, progesterone is the single most important hormone pertaining to receptivity and the window of implantation. Once progesterone levels reach a critical threshold, a well-timed and orderly secretory transformation begins. Even very low levels of serum progesterone have the capacity to trigger differential expression of key genes associated with the inception of the secretory transformation and ultimately the control of the window of implantation. By ensuring that endogenous progesterone levels are less than 1 nanogram per mil prior to exogenous progesterone start, or HCG trigger, we can help ensure reproducibility of the results, as we know when the secretory clock starts, so that's what I refer to it, and this means we know when the secretory transformation is initiated. Now, I want to share with you what the iGenomics protocol pertaining to endogenous progesterone control is. And I take these directly from the endometrium manual. You can find this online on our website, or if you would like, we can always send you a copy. But overall, endogenous progesterone properly controlled in biopsy and transfer cycles, it must be less than 1 nanogram per mil within the 24 hours prior to the first progesterone intake in an HRT cycle, or at LH plus 0, HCG plus 0 in natural cycles. Now, again, we highlight it must be less than 1 nanogram per mil, but also when is important, the 24 hours prior to first progesterone intake, or at LH plus 0, HCG plus 0. The other important aspect to point out here is that not only does endogenous progesterone need to be properly controlled in the biopsy or the ERA mock cycle, but also in the transfer cycle. So it's very important that you're measuring in this manner in both the mock and PET cycles. Now let's look at HRT cycles directly. So in an HRT cycle, it is very important to ensure that there is no ovulation, and therefore endogenous progesterone levels should always be measured within the 24 hours prior to the first progesterone intake. The levels should be less than 1 nanogram per mil. If it is not, then our recommendation is to cancel the cycle and start a new one. Because again, if we see endogenous progesterone levels greater than 1 nanogram per mil, we can't ensure when that secretory clock has started. This is going to affect our ability to reproduce the same scenario in the next transfer cycle. Failure to properly control for endogenous progesterone may result in an endogenous progesterone artifact that can affect the accuracy and reproducibility of the ERA results. So again, looking at the schematic, the patient's on about 10 days of exogenous estradiol. Around 10 days, we see that the endometrium is trilaminar, greater than 6 millimeters, and we check endogenous progesterone, it is less than 1 nanogram per mil. We're going to start exogenous progesterone within the next 24 hours. Now, what about a natural cycle? To ensure that there is no endogenous progesterone escape by the time of HCG trigger or LH surge, the endogenous progesterone level should always be measured at HCG plus 0 or LH plus 0, and again, should be less than 1 nanogram per mil. Otherwise, the recommendation is to cancel the cycle and start a new one. As in HRT cycle, failure to properly control the endogenous progesterone may result in an endogenous progesterone artifact that can affect the accuracy and reproducibility of the ERA results. So referring to the schematic we see here, if the patient has their surge, not only do you want to check LH levels, but check progesterone levels to make sure they're less than 1 nanogram per mil. If you are giving an HCG trigger over using LH surge, then day of HCG trigger, progesterone should also be measured and ensure that it's less than 1 nanogram per mil. Now, we do use 1 nanogram per mil as a cutoff. It is conservative, but as I mentioned before, even small concentrations of serum progesterone can initiate that secretory phase. So we want to make sure that we know exactly when the patient has her first exposure over that threshold to initiate the movement to the window of implantation. Now, you also are probably familiar with our test requisition form. We do have a lot of information on the test requisition form. We are completely aware of that, and we appreciate your patience when filling this out because we know it is a fair amount of data. The reason here is because we want to help ensure reproducibility. And I think this is quite evident. I've had the comment before, it's like, well, maybe your competitor, their requisition form is much shorter. The issue here is that if we can't ensure reproducibility and we can't ensure proper protocol compliance, we can't ensure the best clinical outcomes for patients. And this is actually evident if you look at the clinical outcomes presented in different publications, particularly external publications about ERA versus maybe clinical outcomes about some competitor tests. You'll see that our clinical outcomes are always much higher than our competitors. And I think a lot of this has to do with ensuring proper protocol compliance to ensure proper reproducibility for patients. So on the requisition form, I believe it's page 2, there's information about endogenous progesterone measurement. And you can see here, we do give the protocol. It needs to be measured on LH plus 0 or HCG plus 0 in a natural cycle, or within 24 hours prior to starting exogenous progesterone. We'll ask you to put in the measurement itself in nanograms per mil, and then the date measured. And what we should see is that the date measured should be the day prior to exogenous progesterone start. So let's run through some scenarios of what can happen if endogenous progesterone is not properly controlled. So here we have our ERA mock cycle. We did measure endogenous progesterone properly, and it was less than 1 nanogram per mil within the 24 hours of progesterone start. We performed the biopsy at 120 hours, and the result indicated a pre-receptive profile with recommendation to perform a personalized embryo transfer 24 hours later. So 120 plus 24 is 144. So we go on to our personalized embryo transfer cycle, but this time endogenous progesterone is not controlled. The patient's level is actually greater than 1 nanogram per mil within the 24 hours of progesterone start. But since we're not considering our endogenous progesterone, we go ahead and transfer that embryo at 144 like the report says. But since the patient already had an initial rise before her first intake of exogenous progesterone, she already started that secretory clock. So instead of transferring during the receptive phase at 144, we're now in the post-receptive phase at 144. So we're transferring an embryo into a window that has already closed, meaning that there's practically no chance of implantation, because once that window is closed, we're done for that cycle. And again, this is because small concentrations of progesterone can initiate the secretory transformation of the endometrium. So you can clearly see here why controlling for endogenous progesterone is extremely important. We don't want to end up transferring precious embryos at a time in which the window of implantation is already closed, even though we replicated everything else perfectly between the two cycles. So just one of these variables being affected can affect the entire outcome. Now let's look at another example. In this case, we undergo the ERA mock cycle, and endogenous progesterone is not even measured. So we don't know what our level is. We go ahead and perform the biopsy at 120 hours as indicated, and we receive a post-receptive result. Now, as probably many of you know, anytime a post-receptive result is obtained, you normally will have a recommendation to perform a second biopsy 24 hours sooner. So in this case, we receive a post-receptive result. We find that she is, her window of implantation is already passed. We're going to say perform a second biopsy 24 hours earlier at 96 hours. But because we did not measure endogenous progesterone, these questions come into our mind. Is my patient really post-receptive, or perhaps her endogenous progesterone was elevated? Can the result be trusted? What if the patient had an early endogenous progesterone escape and the endometrium is prematurely advanced compared to the first exogenous progesterone timing? Because again, the timing started a bit sooner than we had anticipated with our first exogenous intake. Does my patient need to undergo a second biopsy unnecessarily? If I do properly control endogenous progesterone in the second biopsy cycle and the results do not correlate, now what? So what if at 96 hours we obtain a pre-receptive 2-day result? Does my patient need to undergo a third biopsy now? Because this wouldn't make sense. So we do see this sometimes. We'll see, okay, biopsy performed at 120 hours, no control of endogenous progesterone, post-receptive result. Biopsy at 96 hours is indicating receptivity 48 hours later at 144 hours. Well, if the results properly correlated, because let's say endogenous progesterone was okay, we should see that there is either we find receptivity at 96 or the window of implantation is flanked somewhere between 96 and 120 hours because the patient may have a narrow window of implantation. But if we see a completely different results at the second biopsy, then we could pretty much assume that the first biopsy, an elevated endogenous progesterone level was at play and led to an erroneous result. Because again, small concentrations of progesterone can initiate the secretory transformation of the endometrium. So again, what can happen if endogenous progesterone is not properly controlled? So this was a retrospective study published in 2022 by the Shady Grove Fertility Group. And when you actually look at their materials and methods, they indicated serum progesterone concentration should be less than 1 nanogram per mil or at the primary physician's discretion. Okay, well, let's look at the first part. Serum progesterone concentration less than 1 nanogram per mil. That's great. That matches halfway with our protocol. However, when? Within 24 hours, within 2 days, within 5 days? Because I've seen many ERA come through where maybe the endogenous progesterone was checked on day 2 of the cycle. Well, yes, we're going to see very low levels of progesterone at that time, but what about the 24 hours before exogenous start? This is important. And then the second part, at the primary physician's discretion, meaning that it wasn't measured. Okay. Now we go on to another publication by the same group. So again, Shady Grove Fertility. This was their 2022 publication for their randomized controlled trial. And we look at the materials and methods in which they talk about serum progesterone control. And they then use the cutoff of less than 1.5 nanogram per mil. Now, again, this is a protocol deviation right off the bat because our protocol is less than 1 nanogram per mil. And then again, they don't indicate when. Was this measured within 24 hours in their clinic, 2 days, 5 days? It's not indicated. So big differences in clinical outcomes when complete protocol compliance, including proper endogenous progesterone control, is carried out can be seen. So what I'm trying to refer here to is that when we're reading these publications, we have to keep in the back of our mind, was proper protocol compliance achieved in all of the cycles? Was it carried out properly? What were the cutoffs used? And what were the protocols applied in each of those papers? Because we know if we looked at the previous example between the EV patients in the Causalino retrospective study versus the EV patients in the iGenomics RCT study, we see huge differences between the ERA groups in each study. So again, when we're achieving statistically significantly higher clinical outcomes in the PET group with the clean data verified with proper protocol compliance, we see a bit of the opposite when there's no veritable control over proper protocol compliance in the retrospective study. So again, proper protocol compliance is the key to these high clinical outcomes. So conclusions here, small concentrations of endogenous progesterone can initiate the secretory transformation of the endometrium. Failure to properly control for endogenous progesterone may result in an endogenous progesterone artifact that can affect the accuracy and reproducibility of the ERA results. Unnecessary additional biopsies for the patient can happen if endogenous progesterone is not controlled. If we think back to that example a few slides ago where we didn't measure, we got a post-receptive result, and then we started questioning, is this really post-receptive? Is it not? If in the same scenario, endogenous progesterone was controlled, maybe the patient would have had a direct recommendation for transfer. And then we know that unnecessary additional biopsies for patients mean unnecessary cost and unnecessary time for patients. Transfer into a non-receptive endometrium, if an endogenous progesterone artifact does exist, can lead to failed transfer and poor clinical outcomes for patients. Consideration of proper protocol compliance, including endogenous progesterone control, in studies is imperative when considering the results. And finally, properly measuring endogenous progesterone to ensure optimal clinical outcomes for your patients by ensuring these levels are less than 1 nanogram per mil within the 24 hours of exogenous progesterone and HRT cycle, or less than 1 nanogram per mil on day of HCG trigger or LH surge. So that brings us to the end of our presentation. Hopefully I was able to bring some enlightenment and new news there, a new perspective. And I think Vikram, maybe now is the time we can open up for any Q&As that may be written in the chat box.
Yeah, we have quite a few of them. First of all, let me thank you, Tiffany, for your enlightening talk. And I'm sure the doctors in the audience, they must be also feeling that this was quite refreshing. It was not monotonous. And we at iGenomics are really, really very careful when it comes to following the PER protocol, because ultimately, what is the goal at both ends, whether it's the doctors in the audience or iGenomics? The goal is to give the best to the patient. So, that is why this program, this webinar was so necessary. So, thank you again, Tiffany, and thank you very much, doctors out there in the audience, for being so attentive and patient with us. So, give me the time to read out your questions to Tiffany. Yeah, Tiffany, I'm starting. There is a question that I did embryo transfer as per error test. It ended up with abortion. What could be the probable reason?
So ERA is mostly to help with implantation failure. So really the first, goal is to have positive implantation by properly synchronizing the embryo to the endometrium. Now, we do see that there are some women with biochemical pregnancy maybe at risk of having a displaced window of implantation, but when we think of ERA, we think of implantation failure. Now, pregnancy loss, that may have to do with, obviously, embryo aneuploidy is a big culprit into miscarriage. But if we're talking about the endometrium, that probably more relates to microbiome. We know that certain pathogens or the presence of pathogens can not only lead to implantation failure, but can also lead to miscarriage. So most likely that the miscarriage, depending upon how far in the pregnancy occurred, is not related to receptivity. But if we're looking at an endometrial factor, perhaps more to the endometrial, the health of the endometrial microbiome, and the potential that there was either a pathogenic or dysbiotic microbiome present at the time of the pregnancy.
Hope this answers your question, doctor. Thanks, Stephanie. I'll go to the next one. Do we need to repeat ERA if the result comes pre-receptive or post-receptive?
Sure. So we recommend a repeat biopsy with a post-receptive result. So that's going to say biopsy 24 hours earlier. We also recommend a repeat biopsy with a pre-receptive 2-day result. So the patient will need an additional 48 hours of progesterone. Now, if you receive a pre-receptive 1-day result, indicating just 24 hours more progesterone, then you'll receive a direct recommendation for transfer in most cases. So it's really only the post-receptive and pre-receptive 2 days a recommended second biopsy will be made, and that constitutes about less than 10% of the cases we receive worldwide.
Wonderful. Thanks a lot, Tiffany. Another one is, does antibiotic course given to the patient in between ERA mock and transfer cycle also affect the reproducibility?
We don't believe antibiotics will affect the reproducibility of the results if you're giving them in between the mock cycle and transfer cycle. Again, that's going to affect more of the microbiome. So if you are performing the EMA test, which is the endometrial microbiome test, or the endometrio test, which is the ERA plus EMA and ALICE, we don't recommend the use of the antibiotics because it can affect the patient's bacteria in her body, including the endometrium. But for ERA, we don't suspect that it affects the reproducibility of the ERA results.
Thanks, Taya. We have another question. Does the estrogen type, dose, and days also need to be exactly the same in mock and transfer cycle?
So this is a great question. We get this a lot because we're always like replicate everything, replicate everything, replicate everything. Now, when we say replicate everything, everything, this is more for progesterone medications used in the cycle. Estrogen we can be a little bit more malleable with, and that's the one thing it depends upon is that the endometrium is building the same. So let's say you use the same estradiol in the mock and transfer cycle, but maybe in the mock cycle you use 10 days, but you find that the patient's lining is not building as quickly as it did in the mock cycle. You can certainly add on more days of estradiol or even change the estradiol if you want, as long as the endometrial conditions are similar. So again, you want to have the thickness that is comparable between the mock cycle and the transfer cycle. That's the important part when I think it comes to the first half of the cycle and the medication pertaining to that. So a quick summary of that answer is that No, for the estradiol, it does not have to be replicated exactly, but for progesterone, it absolutely needs to be replicated exactly. And Vikram, before you go on to the next question, another point I'd like to make that maybe a lot of physicians and patients aren't aware of, that replication of the progesterone protocol needs to be replicated exactly between the mock and the transfer cycle up until you transfer the embryo. If you need to make any adjustments to the progesterone after the embryo transfer, that's certainly okay because we just want to get the patient to where we know they're receptive and introduce the embryo to a receptive endometrium. After embryo transfer occurs, you can change the protocol for progesterone any way you would like. It just needs to be replicated up until that point.
Tiffany, I think you answered the second part of this question
Oh,
also, but
perfect.
it's my duty to read out the second portion of this question. What if the endometrial thickness was appropriate in the mock cycle with the dose, with that particular dose, but it's not the same in the transfer cycle? Can we change the dose of estrogen in transfer cycle? I think you have replied to that, but still, over to you.
Yes, you can change the dose to help replicate the endometrial thickness. However, if in the end you're not able to obtain the proper endometrial thickness, so it's replicated between the two cycles, we recommend canceling that cycle and then trying again in the next cycle. Um, so for the most part, we recommend not going past 17 days of estradiol priming before starting progesterone, particularly in the ERA mock cycle, because this can lead to endometrial bleeding and increase your chance of a non-informative result. But again, if you don't obtain the same endometrial condition even after changing the estradiol, um, then it's best just to cancel that cycle and then try again next month.
Thank you, Tiffany. Uh, we have this question. Does the length of HRT cycle before starting progesterone supplementation affect the window of implantation?
I think it probably pertains to just what I mentioned before. Um, we recommend not to exceed 17 days of estradiol priming before the progesterone start, just because this can increase the chance of endometrial bleeding, which we've found association with a non-informative ERA result. So this can put the patient at risk of this, but we also leave it to the discretion of the physician. But just so you're aware, there is a increased risk of the endometrial bleeding and potential for non-informative ERA result, which again would require the patient to undergo a new biopsy and a new cycle.
Well, okay. Uh, we have another question. How did iGenomics arrive at 1 nanogram per ml as P4 cutoff?
Well, as I mentioned, we know that very small concentrations of progesterone can initiate the secretory phase transformation, and this has been in several publications. 1 nanogram per mil is a more conservative cutoff. We're aware of that, but that's to again ensure that there's absolutely no influence of endogenous progesterone on initiating that secretory change. And being that our presence is worldwide, we know that there can be differences from one, emulate from another. So we want to make sure we have the most conservative view that covers all of the progesterone measurement worldwide, because again, there's going to be a difference between, even if you're running on the same machine using the same reagents. You run the patient's same blood at one clinic versus another, the progesterone can be off just by a little. So the 1 nanogram per mil is the conservative view to make sure that the secretory phase change hasn't been initiated.
Thanks, Tiffany. Uh, Another question is how does one select the time for biopsy for a natural cycle FET, especially if HCG trigger is not given and transfer is based purely on LH levels?
Yes, a natural cycle with the LH surge can be quite tricky, especially for patients with a narrow window of implantation. So when I speak of narrow window of implantation, we've seen patients whose window of implantation is less than 24 hours, some less than 12 hours. So timing is very crucial, particularly in these patient cases. For this reason, when using a natural cycle, we do recommend the use of HCG over LH surge because it gives you more control as a physician and it allows you to control better the actual duration between the trigger and transfer. So we can time and synchronize the transfer according to when the endometrium is ready and when the embryo is ready. So with the LH surge, again, it's a little bit trickier because we're not as precise with the timing. We also have to make sure we're detecting the LH surge properly. And if you review our manual, that is that you have a negative, positive, negative pattern of LH measurements within 3 consecutive days. And then we designate that positive day as LH surge day. But again, this can be certainly tricky because maybe LH surge was at 8 a.m. or 8 p.m. or 2 a.m. or 2 p.m. And if you have a recommendation to transfer, let's say at 180 hours of progesterone, then I'm sorry, after LH surge, then that can be a little bit tricky to carry out. So the HCG trigger overcomes that and allows you to have more preciseness in a natural cycle.
Hope that answers your question, doctor. Now, there is another question not pertaining to ERA, but it's pertaining to the embryo. So I'm just throwing it at you. Uh, how representative is the trophectoderm of the inner cell mass? What is the probability that an embryo labeled as abnormal could actually be normal?
I see. So we're referring to mosaicism, so a difference between the the chromosomes in count in the trophectoderm versus the ICM. Um, we see that there is fair concordance. Um, I'm really not the best person to answer this. I know my background is in embryology and PGTA, but I don't have the most up-to-date data to share that. We'll have to pass that one on to Nasser.
Okay, okay, I'll do that. Dr. Bala, we'll get back to you on this. Another question, moving to another one. If a patient has a live birth following a PET after ARA, do we need to repeat it for the second pregnancy if the delivery was by C-section? Then, in parentheses, assuming ARA may be affected by a surgery on the cavity.
So that is a great question. It's one that we receive frequently. So we haven't studied the effects of cesarean on the reproducibility of the ERA results. However, for some of the preliminary data that we receive from some of our colleagues in the field, we see that there is consistency. Now, I think what is more of a concern here is the time between the ERA, the initial ERA biopsy, and this subsequent transfer for baby number 2. As I mentioned, we've shown that the ERA results are reproducible up to 40 months. Now, probably they're reproducible beyond 40 months. It's just that 40 months was what we went up to. So if it's in within 2 to 3 years, and let's say the patient hasn't had significant change to BMI, so she's approximately the same BMI she was now during the mock cycle, and her endometrium is building similarly. So let's say she had 8 millimeters in the mock cycle and she's building 8 millimeters in this new transfer cycle, then we recommend following the initial ERA recommendation, again, replicating the protocols exactly, and transferring her next embryo. Now, if she has any changes, so let's say her BMI has increased significantly between her ERA mock cycle and now her current BMI, or her endometrial lining is not building in the same fashion. So maybe it is now less than 6 millimeters, where before it was greater than 6 millimeters. Then we recommend repeating the ERA because there could be a potential that her window of implantation has been affected.
Thank you, Tiffany. Moving on to another one. If we are planning for a natural cycle FET and the patient has already undergone ERA, how much difference can we expect, if any?
So I'm sorry, Vikram, is this if they do an HRT in the mock
Yeah,
cycle?
no, it is like ERA has been done, but
Yeah.
the embryo is transferred, it's an FET. Maybe they don't follow the ERA recommendation. So what would be the difference? I can make this out of the question. If we are planning for a natural cycle FET
Mhm.
and the patient has undergone an HRT ERA,
Okay.
yeah, if you can make it out.
So we don't know for each patient case. So the endometrial receptivity is so personalized for each woman, and we know that um, even just minor changes within the same cycle type can affect her window of implantation. So I know this question is saying from HRT to natural, what is the concordance between the results? There could be concordance, there could not be concordance. So it's so patient dependent. So for that reason, we can't carry over the results of one cycle type to another. So for instance, let's say she's receptive at 120 hours in HRT. That doesn't mean that she'll be receptive at the normal timing in a natural cycle at 168 hours from HCG trigger. We can find that she is post-receptive or pre-receptive. So for this reason, replicating the cycles exactly is extremely important to ensure reproducibility. So we're accurately identifying the window of implantation and we're accurately transferring during the window of implantation. And as I said, even within the same cycle type, so perhaps we have an HRT cycle in the mock and an HRT cycle in the transfer. But let's say we used vaginal progesterone in the mock, and then in the transfer, we used IM progesterone. Those results won't necessarily correlate because any change in to any of the protocol can affect how the woman's endometrium responds and can affect her transcriptomic signature. So it's important that we replicate exactly. I always explain the ERA as a science experiment, that we need to keep all our variables the same. The only thing that we should be changing is the timing if indicated to do so. But if we start changing different variables beyond timing, then we don't know what variable is affecting what on the window of implantation. So again, only variable to be changed is the timing.
Well, hope this answers your question, doctor. Another one is in HRT cycle, if there is no dominant follicle, therefore there would be no ovulation, good proliferative endometrium. Hence, do we still need to measure P4 levels? Because why should P4 rise?
Yeah, we get this question a lot. It's like, well, I didn't see a follicle, or there were no follicles present. And obviously we need the follicle to ovulate in order for endogenous progesterone to be produced. My answer to this is just to take the endogenous progesterone to be sure, because we've seen some patients who have elevated endogenous progesterones even through the proliferative phase or the follicular phase, even when there's no follicles present. Um, so it's not common, but it can happen. And again, just to be safe, it's puts your mind at ease knowing that everything is controlled for, and then the results are completely reproducible. So we'll also get this question too: if the patient's maybe on Lupron, then she doesn't need to have the endogenous progesterone measured. But again, maybe the patient forgot to take her medication or isn't taking it properly, and she did have ovulation, and an endogenous progesterone is present. So again, it's very, I know it's very conservative, um, but I think it's better to be safe than sorry, especially when we're at transfer and we could potentially be transferring at the wrong time. So endogenous progesterone, I would say, is probably one of the more important aspects to consider and to carry out when performing ERA.
Thanks, Tiffany. Another one uh, is error result different in each cycle in the same patient?
So we showed that a bit earlier in the slide deck. We had the one Canadian clinic that published about their patient who underwent 4 different biopsies. Now, as what we can see, they did replicate the cycles, and we saw a nice transformation of the endometrium going from about 106 hours to I think it was 190 hours. And we see that the endometrium went through each phase and that the transcriptomic signatures were consistent through those phases through that time spectrum. So again, in our own work, we saw that the results are reproducible up to 40 months. Now, if you do change anything, such as the cycle protocol or the patient's BMI or the patient's endometrial conditions change, then this can affect the window of implantation um, from month to month for the patient. But again, even in our earlier study, we looked at natural cycles for patients, and some of the biopsies were taken quite early, day 9 of the cycle. And we saw that even after 3 years, the transcriptomic signatures were the same in those women. So there is very little change in transcriptomic profiles from month to month. The big things that can affect it are the external factors, like I said, change in protocol, change in BMI, and things like that.
Thank you, Tiffany. Uh, Another one is whether it's recommended to biopsy both the horns of the uterus separately in women with two distinct horns.
So we do recommend to biopsy both, and when we provide the results, we'll provide a result for the left horn and the right. So we ask when you perform the biopsy to label the cryotube which one is from the right and which one is from the left, so we can correlate those results accordingly.
Great. Uh, Again, there is this question. I think this has been already addressed. Latest validity period of an error report. I think it's 40 months,
For,
unless there are some changes.
yeah, so we found that the ERA results are reproducible up to 40 months.
Right.
When, again, you're replicating conditions and protocol.
And are there any parameters like we say, Tiffany, many a times that there should not be significant change in the BMI during this period, or there should not be any surgical intervention in the uterine or reproductive tract? So only then the report will hold valid, or is it like how it is?
No, that those stipulations are a part of the reproducibility, because if we do see significant change in BMI, this could affect the reproducibility in that patient. If we do see changes to how the endometrium builds or conditions, this also could affect the reproducibility. So yes, the results are reproducible up to 40 months under replicated conditions and protocol.
Thanks. I think this question also has been taken up during your presentation. Most recent studies in high impact journals show no additional benefit of ERA. What's your response regarding this?
I think again, not only do we have to look at the materials and methods to make sure that proper protocol was applied, because even in our own study, I said we saw 50% dropout rate because of no protocol compliance. And this is very important to consider when we're reading different papers. But also we need to look at who was the indicated or the studied population in those papers. So the more recent papers that came out, particularly the Shady Grove Fertility RCT, was in good prognosis patients. So these are patients who are not indicated for ERA. So ERA is reserved particularly for those patients with recurrent implantation failure. As I mentioned, ERA was brought to the market as a solution for these patients. ERA can also be applied to patients where I said maybe with a higher BMI, since we see increased risk of a displaced window of implantation. Patients with adenomyosis, we see increased displacement in these patients. Even patients with a history of biochemical pregnancy loss, because we see that these patients tend to be associated with transferring towards the end of their window of implantation. But if we look at these more recent papers, these are in patients, good prognosis patients without recurrent implantation failure. So what we see is that their transcriptomic profiles, even if they're, say, in the pre-receptive range, they're still quite close to the receptive range, meaning that that shift of 24 hours isn't as significant for them versus patients with RAF who have much more displaced windows and who more heavily benefit from a 24-hour change in this example. So I would say those are the important considerations to keep in mind. Who are the patients that they're studying? Are they the indicated population? And was the proper protocol followed? Because we see again a big difference in the same IVF clinic when we use the clean data versus when we use the unclean data. So I hope that's a helpful explanation.
Thanks, Stephanie. Well, a question is here which says, if the embryo selected for transfer is euploid, unless the embryo selected for transfer is euploid, error doesn't have much meaning. What's your thought?
So if you know you're transferring a euploid embryo, obviously the embryo and the endometrium are the two big players when it comes to implantation. Now, I do think embryo aneuploidy is a bit of a heavier hitter, I should say, because if we know that it's aneuploid, it's most likely not going to be a successful outcome. But I don't think we could say if we don't do PGTA testing, ERA is not beneficial because we have been transferring embryos for years without PGTA testing, and we know that a fair amount are going to lead to successful live birth because they were euploid. So the whether the embryo is euploid or not does not affect the receptivity. So I think if your patient, for example, is not undergoing PGTA, at least we can control the other side of the implantation process and optimize the endometrium, because maybe that embryo is euploid even though you didn't do PGTA testing for it. So I don't think, receptivity depends on the the chromosome status of the embryo or a requirement to have PGTA. You can only, in my opinion, you can optimize further by controlling for aneuploidy and receptivity, but you could still optimize with either aneuploidy alone or receptivity alone. It doesn't require both. Um, we could just imagine that we get further optimization per cycle when we do control for both.
Tiffany, what's your opinion on checking serum P4 level 1 day prior to embryo transfer in an ERA compliant cycle?
So this is not a requirement in our protocol. And I'm sorry, Victor, you said 1 day prior to transfer?
To transfer, exactly.
Yeah, this is not required in our protocol. Um, I know it's a very much common practice to ensure that the patient's progesterone levels are elevated. I know here we usually like them around 10 nanogram per mil, but for ERA, it doesn't affect our results or reproducibility. We're concerned with the endogenous progesterone level prior to the first intake of exogenous progesterone. So I would say you can use that at your discretion, but we don't feel like it affects the reproducibility of the results.
Well, there is another question from the same distinguished doctor. Uh, what about day 2 progesterone levels?
Same thing. It's up to your discretion. For us, it's not necessary for us to monitor that for ERA, but I can certainly see how it's necessary in the clinical practice for the transfer. But we wouldn't recommend any differences to the protocol based upon these progesterone measurements after the first intake of progesterone. Um, and I know there's sometimes when physicians see that the progesterone levels are not at the levels they would like, um, our recommendation again is to replicate everything up until transfer, and then you can always change your progesterone protocol once the embryo transfer has occurred, because we have ensured that the embryo is introduced to a receptive endometrium, and then from that point on, if you need to make any adjustments to progesterone, you could do so without affecting the reproducibility of the ERA.
Well, another question is, thanks, Stephanie, first of all, for the reply. Another question is, what can be done when results come as insufficient RNA?
So usually insufficient RNA, it's because there's not enough RNA present to perform the test, and that's usually because there's not enough tissue present. Now, we need approximately 70 milligrams of tissue to run the ERA or the endometrial or MR-ALICE test. Um, and it needs to be uh, mostly tissue. So sometimes we can get a sample that looks like it's adequate in size, but if it's made up of primarily blood and mucus and not tissue, this can lead to an insufficient RNA result. So having 70 milligrams of clean tissue can um, uh, help decrease the chance of having an insufficient RNA result.
Again, related to this question, Tiffany, how does a doctor avoid, blood and mucus, into the specimen? Because ultimately it is detrimental during the analysis. We always recommend as less blood and mucus as possible, but ultimately one is dealing with the tissue, the vessels, and which carry a lot of blood. So how does one avoid this situation?
Yeah, it's much easier said than done to say, okay, don't introduce too much blood or tissue. Um, so you can always clean the catheter off after collection with sterile gauze. We don't want to introduce anything not sterile. And then when taking the biopsy, we're aware that it's not just continuous tissue. There's some.
Tiffany, we lost you. Angie, are you there? Ah,
Yes, Vikram, yes, I'm here. I think we have lost the connection,
yeah.
so we
Oh,
can just wait.
I think she's signing on through her phone. Just sorry, doctors, there are a couple of more questions. Just bear with us. She's trying to join through her phone. Well, doctors, I'm sorry if a lot of you had to face some trouble because of Go app. You were asked to download some Go app application, so which is very essential for webinars, particularly when you are attending through your handsets. So I regret this. Just a couple of questions more. Give us a minute, please. I know it's quite late here in India.
Vikram?
Tiffany?
Oh,
Yeah.
I'm back. I apologize. I
Wonderful,
lost
wonderful,
power to my computer.
wonderful. We can understand this all technology, it can
Uh,
conk off any time. Uh, Nobody's fault. Just a few questions more, Tiffany. I
yes.
think we were at results insufficient RNA, right?
Yes. So I was discussing how to avoid with the blood and mucus. So
Yeah.
as I said, to clean off the catheter with sterile gauze, and then also we understand that it's not a continuous piece of tissue when collecting the biopsy. So you can always it's very segmented sometimes in the catheter. You can see segments of blood and mucus. You can see segments of tissue. So you want to expel the blood and tissue, I'm sorry, the blood and mucus before introducing the catheter into the cryotube. And at that point, you can then expel the tissue only. So that's one way to do it. I've heard of physicians also using sterilized scissors to cut the catheter where the tissue is, and that way you're introducing tissue and not the blood and mucus.
Wow. Thank you very much. That's an information for at least me. Thanks a lot for sharing. Uh, Very quickly, uh, what do you do if you get repeated elevated endogenous P4?
So if you have elevated endogenous progesterone before your progesterone, exogenous progesterone start in an HRT cycle or on LH plus 0 or HCG plus 0, we recommend canceling that cycle, whether it's the mock cycle or the transfer cycle, and then repeating in the next cycle. Because again, this is going to affect the reproducibility of the ERA findings.
No, Tiffany, thanks. But the question is, if repeatedly, cycle after cycle, the P4 levels are elevated, then what to do in that case?
Uh, so if you have a patient with elevated high progesterone, these are quite tricky cases. We've had this before. Um, Usually it's due to something innate within the patient, a mutation of sort. In these cases, we can't confirm the reproducibility of the ERA results. I know there may be some different medical protocols that can be used to help decrease the endogenous progesterone. Um, but these cases are sometimes very difficult. Um, you can always try changing the cycle type. Sometimes we see success in lowering endogenous progesterone levels in these particular patients then. Um, but my recommendation is that if you have a patient with um, consistently elevated progesterone levels throughout her menstrual cycle, to speak with our endometrial experts we have internally, and we can provide additional information. So we're always here to support. We do have physicians on staff who can help provide some insight or some recommendations.
Thanks, Tiffany. Okay, another question is, what range in thickness of endometrium in millimeter is acceptable between the mock and the transfer cycle?
Sure. So we give ranges that are reproducible. So for the mock and transfer cycle, the ranges should either be less than 6 millimeters for both cycles, between 6 to 12 millimeters for both cycles, or greater than 12 millimeters for both cycles.
Uh, if I put this question like this, that in mock cycle, the thickness was 7 millimeter, and in the transfer cycle, the thickness is 6.5 millimeter. Does it work, or we need to cancel the cycle?
No, that's completely fine because they're still within the same range. They're between that 6 to 12 millimeters. So
Ah,
again,
ah,
if
ah,
it's
got it.
they should both be either in both cycles either be less than 6 millimeters, between 6 to 12 millimeters, or greater than 12 millimeters. So you would
Thanks.
cancel if you had maybe mock cycle was 8 millimeters and transfer cycle was 5.5 millimeters. That would constitute, enough of a deviation.
Thank you, Tiffany.
Mhm.
Tiffany, two more questions. Uh, why do you think we should wait for two more failures before going in for error? Usually we say it's not a first appointment test. We should wait for a couple of failures and then give a thought to error. So the question here is, why do you think we should wait for two or more failures before going in for error? If the patient is willing to afford it, why not to do it initially?
I think that's up to the discretion of the physician and patient. We certainly still have patients who have never had an embryo transfer and they want to ensure that they're transferring during their window of implantation and will undergo the ERA test. So I think if we refer to maybe the Shady Grove Fertility RCT, they looked at good prognosis patients. They didn't see an advantage of using ERA, but they also didn't see a disadvantage in the sense that they didn't have poor outcomes with ERA versus traditional FET timing. And so, in that sense, it doesn't harm undergoing the ERA test. I mean, it is an additional cost, an additional time for the mock cycle, um, but it doesn't hurt the patient. So,
we also see the use of ERA, maybe in patients not with recurrent implantation failure, but perhaps they only have one euploid embryo available for transfer, and this is their only shot at it. So they'll undergo the ERA test to ensure again that they're synchronizing properly that one and only blastocyst they have with a receptive endometrium. So a blanket statement would be that the ERA is indicated for recurrent implantation failure, but there are certainly occasions where the ERA can be beneficial outside of that indication.
Thanks, Tiffany. Mm, would you recommend ERA in all PGTA cycles?
I don't think we can recommend ERA in all PGTA cycles because, again, we might have patients who've never had an implantation failure before. This is their first transfer, so it may not be necessary. So again, I don't think having PGTA requires ERA or not having PGTA does not require ERA. I think this alluding to the question we received before. Again, can it optimize? Sure. Ensuring that we're transferring a euploid embryo to a receptive endometrium, but it's not necessary to do on every patient. Because too, we're going to see also a fair amount of patients are receptive at the standard time of transfer. So we see about 30% of patients are going to have a displaced window of implantation, and that's usually reserved for the patients with recurrent implantation failure. Or as I said before, there are some subgroups of patients where we expect a higher displacement rate, such as adenomyosis and patients with a higher BMI greater than 30.
Well, I'll close the session with this last question. In invalid reports, sometimes it is mentioned that the profile does not match. So what does this mean?
I think this is referring to invalid RNA results.
Yeah.
Okay. With invalid RNA results, this occurs because the RNA had degraded, and usually I would say the most potential reason for a degradation of RNA is a sample size that is too large. So such as insufficient RNA, that's when the sample size is too small, but we can also have problems if the sample size is too big, and that leads to invalid RNA. And what happens there is that there's not enough RNA stabilizing buffer to preserve the RNA in the tissue, so the RNA will degrade, and then we get a profile that doesn't fall within the transcriptomic profiles of the various stages of receptivity. So in that case, we can't accept the result and a rebiopsy needs to be performed.
Thank you, Tiffany. So great of you. Thanks, doctors, though many of you have already signed off. But my heartfelt gratitude to all of you for being here with us this evening for this important session. I'm sure you must have taken something home from this session, which was really enlightening. Tiffany, thank you very much for being here with us, Tiffany, this evening in India, and hope to see you soon with another volume of this series of webinar. Thank you very much.
Thank you, everyone.
Thanks, everybody. Bye-bye.